Imagine an incredibly complex plumbing system, like stretching roughly 20 feet long, and it's all coiled up inside this tiny utility closet.
Right.
And as long as the water flows, the pipes flex, the pressure stays balanced, you never even think about it. But the moment something goes wrong.
Oh, yeah, a kinked pipe or a corrosive chemical eating through the walls.
Exactly, or even a glitch in the pressure sensors, the entire house goes into absolute crisis mode.
It's a really delicate physical and chemical balance.
Yeah.
And when that system fails, I mean, the consequences cascade throughout the body within hours.
I'm Harvey. And I'm Donna. We're expert MCCQE reviewers. We'll be breaking down all major concepts covered on the exam. Specifically today, we are tackling gastroenterology diseases of the small and large intestines.
Yeah, and just a quick required disclaimer before we jump in. This deep dive teaches from reliable StatPearls articles. It is for medical education only, not medical advice.
Right?
So clinical decisions should always involve a qualified healthcare provider.
For sure. So our mission today is to help you, the Canadian medical student listening right now, feel completely comfortable with the GI tract.
Because it is heavily tested.
Very heavily tested. We want you to master the high-yield definitions, the presentations, the management, and, honestly, avoid the common exam traps.
Yeah, the test writers love their traps.
Yeah.
I think we should start with the physical hardware of the gut. The mechanical roadblocks.
The acute surgical emergencies.
Exactly. Hernias are like the classic starting point for this. We have this plumbing system trying to squeeze out of weak points in the abdominal wall.
Right, but on the exam, you can't just know it's a hernia. You have to differentiate between an indirect and a direct inguinal hernia.
And the difference really just comes down to embryology versus anatomy.
Okay, so break that down. What's the indirect hernia?
So an indirect inguinal hernia happens because of a congenital defect. During fetal development, the testicles descend through the abdominal wall, and the path they take is supposed to close up behind them.
But sometimes it doesn't.
Right. If that path, which is called the processus vaginalis, if it stays open, it basically leaves a preformed tunnel.
A congenital tunnel.
Yeah. So the bowel just pushes right through the deep inguinal ring, which is located lateral to the inferior epigastric vessels.
Okay, so indirect follows a path that was already there. It's lateral to the vessels. What about the direct hernia?
A direct inguinal hernia is a consequence of wear and tear over time. It doesn't use a preformed tunnel.
It just forces its way through.
Literally. It pushes directly through the abdominal musculature in a weak zone called Hasselbalch's triangle, and that makes it medial to those inferior epigastric vessels.
Medial for direct, lateral for indirect. Got it. So let's talk about the trap here. Let's say you get a vignette about an older male patient with a direct inguinal hernia.
Okay.
He has a noticeable bulge in his groin, but he has absolutely no pain, no nausea, and totally normal bowel movements. The knee-jerk reaction for a lot of students is to send him straight to the operating room to fix the defect.
Which is the classic trap.
Yeah.
You cannot just rush them to the OR.
Right.
Current guidelines actually dictate that for completely asymptomatic inguinal hernias in men, watchful waiting is the standard of care.
Watchful waiting. You just leave it alone.
Yeah, I mean, the risk of the surgery itself often outweighs the risk of the hernia in those specific asymptomatic cases.
Okay, but the exam will also test you on femoral hernias. And from what I recall, the watchful waiting rule goes completely out the window there.
Oh, absolutely. A femoral hernia protrudes lower down below the inguinal ligament entering the femoral canal.
Right, the anatomy is lower.
And demographically, they're incredibly high yield for the boards. Because while inguinal hernias are the most common overall for both men and women, femoral hernias carry a massive 10-to-1 female-to-male ratio.
10-to-1. That's like a neon sign in a clinical vignette. If it's a female patient with a bulge below the inguinal ligament, you're thinking femoral.
Exactly.
But why is the management so aggressive? Like, why can't we just watch and wait if a femoral hernia isn't bothering her?
It comes down to the architecture of the femoral ring itself. Unlike the abdominal wall muscles, which, have some give to them, the boundaries of the femoral ring are totally rigid.
Because it's surrounded by ligaments and bone.
Right. You have the inguinal ligament, the lacunar ligament, and the pubic bone. It does not stretch at all.
So it's a tight squeeze.
A very tight, unforgiving squeeze. So the bowel gets trapped easily, and those rigid walls clamp down on the blood vessels supplying that segment of the intestine.
Which means it loses blood flow.
Yeah, which gives femoral hernias an incredibly high strangulation risk, like 15 to 20%. They always require surgical repair. Always.
Always surgery. Got it. So A hernia is essentially a kink in the pipe from the outside. If the plumbing gets blocked, the whole house backs up.
Which brings us perfectly to bowel obstructions.
Right. And we really have to separate small bowel obstructions, SBOs, from large bowel obstructions, LBOs. The causes and the presentations are distinctly different.
Definitely. In industrialized nations, the most common cause of a small bowel obstruction is actually post-surgical adhesions.
Scar tissue.
Yeah, when a patient has prior abdominal surgery, the body forms scar tissue as it heals, and these bands of scar tissue can literally wrap around the small bowel like a tight rubber band.
And because that blockage is pretty high up in the GI tract, the presentation is quite specific, right?
Right. The patient presents with intermittent colicky pain, and they have frequent large volume vomiting.
And the key detail there is that the vomit is bilious.
Yes. Bilious vomiting, meaning it's green because it contains bile from the liver.
Contrast that with the lower plumbing, the large bowel obstruction. The most common cause there isn't scar tissue.
No, unfortunately, it's usually malignancy, specifically adenocarcinoma.
Right. And the pain isn't usually colicky either. It's more of a continuous dull ache.
And because the blockage is much further down the line, the abdomen becomes markedly distended before the vomiting even starts.
The backup takes longer to reach the stomach.
Exactly. And when the vomiting finally does happen, it's intermittent and feculent.
Feculent, which is exactly as awful as it sounds.
It really is.
So for diagnosing either type of obstruction, what's the standard of care?
The gold standard is an abdominal CT scan with oral contrast. You are looking for the exact transition point.
The transition point, where the plumbing goes from backed up to totally empty.
Exactly. It's the anatomical location where you see dilated, fluid-filled bowel proximal to the blockage, and entirely collapsed, empty bowel distal to it.
And on top of the imaging, you're checking lab values. And lactic acid is the big red flag here, isn't it?
Oh, huge red flag. A rising lactic acid means tissue is actively dying.
Right, microperforations or ischemia.
Yeah.
So standard management involves IV fluids and putting a nasogastric tube down the patient's nose into their stomach.
Just to decompress that back up. Pull the fluid out.
But there's a specific scenario, a closed loop obstruction, that turns this from like a waiting game into an absolute surgical emergency.
A closed loop obstruction is terrifying. It means a segment of bowel is clamped shut at two different points.
Like tying off a balloon at both ends.
Perfect analogy. Because the lining of the bowel, it continuously secretes fluids and gas. But in a closed loop, those secretions have nowhere to go.
So the pressure inside that trapped segment just skyrockets.
It does. And when that pressure builds, it causes a very specific vascular cascade that you need to understand.
Walk us through that cascade, because the exam will test the mechanism.
So venous blood pressure is much lower than arterial blood pressure. As the pressure inside the bowel cavity rises, it compresses the veins first.
Okay, so the low pressure drainage gets cut off.
Right. But blood is still being pumped into the bowel wall by the high-pressure arteries. It just can't drain out.
So the tissue just swells up?
Massively. It becomes engorged with blood, swelling up with extreme edema. And eventually the swelling gets so severe that it chokes off the arterial supply as well.
And once the arteries are choked off, the tissue is starved of oxygen.
Progressing rapidly to ischemia and then frank necrosis. And if that dead, decaying bowel wall tears open,
you get fecal content spilling into the sterile abdominal cavity,
leading to peritonitis and septic shock. The mortality rate for an untreated strangulated bowel is near 100%.
Wow. Okay, so surgery can fix the plumbing if the blockage is on the outside, like an adhesion or a tight hernia ring.
Yeah.
But what if the pipe itself is, thickening and swelling shut from the inside?
That is a great transition.
Yeah.
Because the most common cause of a benign stricture leading to an obstruction in adults brings us into our next major topic.
Inflammatory bowel disease, IBD.
Yes. And for the MCCQE, you absolutely need to distinguish between Crohn's disease and ulcerative colitis.
I actually use a specific visual for this that I find super helpful.
Oh, let's hear it.
Think of Crohn's disease like a termite infestation eating through the entire wall of a house. It causes deep structural damage.
I like that.
But ulcerative colitis, you see, is like a severe chemical burn, but it is strictly limited to the surface of the wallpaper.
That is a fantastic analogy. Let's examine the termites first, then.
Crohn's.
Right. Crohn's disease is driven by an overactive immune response, specifically the Th1 and Th17 helper T-cell pathways.
So the immune system is the termite.
Exactly. These cells mistakenly identify harmless gut bacteria or even food particles as threats, so they recruit macrophages to wall off the perceived threat.
Forming those tightly packed clusters of immune cells?
Yes, the non-case-eating granulomas. And this intense inflammation, it doesn't just sit on the surface. Like your analogy, it is transmural.
It bores through the entire thickness of the bowel wall.
And the weird part is, it doesn't affect the GI tract evenly. You get patches of severe inflammation sitting right next to perfectly healthy tissue,
The classic skip lesions.
which give the intestinal lining that famous cobblestone appearance when you look at it on a scope.
And clinically, Crohn's can strike anywhere from the mouth to the anus.
It can, but it heavily favors the terminal ileum. That's the very end of the small intestine, sitting in the right lower quadrant of the abdomen.
Which is why it frequently causes pain that perfectly mimics acute appendicitis.
That's a huge clinical presentation to watch out for. And furthermore, because the terminal ileum is damaged, patients lose the ability to absorb certain things.
Like vitamin B12 and bile acids.
Exactly, leading to malabsorption issues.
So if we follow the termite analogy, because that inflammation destroys the entire thickness of the wall, you get deep structural complications.
Right.
What happens to the surrounding organs when a transmural ulcer just keeps digging?
Well, the body attempts to heal the deep ulcer, right? But instead of just scabbing over, it forms a tunnel.
A fistula.
A fistula. The bowel literally tunnels through the inflammatory tissue into whatever is sitting next door.
So if it tunnels into the bladder,
You get an enterovesicular fistula.
how does that present on the exam?
The patient will present with recurrent urinary tract infections and pneumaturia.
Which is actual air bubbles in their urine.
Yeah, air from the bowel entering the bladder. Or the tunnel can go straight through the abdominal muscles to the outside of the body,
An enterocutaneous fistula.
leaking bowel contents directly onto the skin. It's really devastating.
So that's the deep tunneling of Crohn's. Now let's contrast that with the chemical burn on the wallpaper. Ulcerative colitis.
Ulcerative colitis is restricted entirely to the mucosal and submucosal layers. It does not go deeper.
The superficial layers.
Right. And it almost always begins in the rectum and spreads continuously, proximally, up the colon.
So no skip lesions.
No skip lesions.
Got it.
And it does not affect the small intestine at all.
Just the colon. And because the superficial lining of the rectum is raw, bleeding, and, constantly inflamed,
The classic presentation is bloody diarrhea accompanied by tenesmus.
tenesmus, that's that constant, really painful sensation that you need to pass stool, even if your bowels are totally empty.
Because the inflamed rectum is just sending false stretch signals to the brain.
It's awful. But there's a bizarre paradox with UC that test writers absolutely love to use.
That smoking paradox.
Yes. Having a prior appendectomy and currently smoking cigarettes are actually associated with a milder disease course in ulcerative colitis.
Which feels so counterintuitive, right?
Yeah.
But nicotine actually alters colonic mucus production and exerts a localized immunosuppressive effect on the mucosal layer of the colon.
So a classic exam vignette will feature a patient, maybe in their 20s or 30s, who recently made a positive life choice.
They finally quit smoking.
Right. But then, a few months later, they suddenly develop severe bloody diarrhea.
And the instinct for the student might be to look for an infection, like C. diff.
But the cessation of smoking simply unmasked their underlying ulcerative colitis.
They removed the nicotine Band-Aid, and the disease just flared right up.
Such a great exam trap. We also have to watch for toxic megacolon with UC, right?
Definitely. While the inflammation in UC usually stays superficial, during a really severe flare, it can penetrate deeper.
Down into the muscularis propria layer.
And that inflammation damages the nerves controlling peristalsis. So the colon loses all its motor tone, it dilates massively, and it acts like a balloon about to pop.
And toxic megacolon is actually the leading cause of death in acute UC flares.
It is. And long-term, you also have to worry about the cumulative risk of colorectal cancer.
Right, because of the constant cycle of cell damage and repair over years.
Yeah, after 30 years of the disease, up to 30% of UC patients may develop colon cancer. It's also highly associated with primary sclerosing cholangitis.
That's the autoimmune liver disease.
Exactly.
So to distinguish between Crohn's and UC on an exam, beyond just the symptoms, you might see serum antibody markers.
PANCA is an immune marker frequently positive in UC.
And ASCA.
ASCA, which is actually an antibody against a common yeast, is more frequently elevated in Crohn's.
You might also be tested on fecal calprotectin. I think we should explain fecal calprotectin because it's an incredibly useful tool clinically.
It really is. Calprotectin is a protein found inside neutrophils, the white blood cells that fight inflammation. If there is active inflammation in the bowel wall, neutrophils migrate there, they die, and they shed this protein directly into the stool.
So if you test a patient with chronic diarrhea and their fecal calprotectin is completely normal,
You can almost entirely rule out active inflammatory bowel disease.
it's a great rule-out test. Now, what about the surgical management for these two?
Well, the surgery really highlights their distinct pathologies. A total colectomy, literally removing the entire large intestine, is essentially curative for ulcerative colitis.
Because you are removing the only organ it affects,
Exactly. But for Crohn's, surgery is only used to manage complications.
like cutting out a stricture or a fistula.
Right. Because Crohn's can affect the entire GI tract. If you remove one inflamed segment, the disease will inevitably just recur somewhere else.
It's systemic in the gut. Okay, so we've covered the mechanical blocks like hernias and the intrinsic inflammatory destruction of Crohn's in UC.
The things you can clearly see.
Right, we can see the damage on a CT scan or an endoscopy. But what happens when a patient is suffering from terrible abdominal pain and diarrhea? You perform a full colonoscopy, and the mucosal lining looks completely flawless.
This requires distinguishing between benign functional disorders, where the gut just behaves erratically, and dangerous genetic mimics that hide on a microscopic level.
Let's start with the functional side. Irritable bowel syndrome, or IBS, is obviously the most common functional disorder.
For sure. The gut looks normal, but the motility is totally dysregulated.
And the diagnosis relies strictly on the Röhm-Pfeff criteria.
You need to know these criteria. You need to see abdominal pain occurring at least 1 day a week for the past 3 months.
But pain alone isn't enough, right?
No. It must be associated with 2 or more of the following. The pain improves or worsens with defecation, there's a noticeable change in how often they stool, or there's a change in the form and appearance of the stool.
The Röhm-Pfeff criteria really help define IBS, but the major trap for medical students here is that diagnosing IBS absolutely requires the absence of alarm symptoms.
Yes, that is crucial.
If your patient meets all the Röhm-Pfeff criteria, but they also report unexplained weight loss or nocturnal diarrhea that wakes them up from a dead sleep,
Or rectal bleeding, or laboratory evidence of iron deficiency anemia?
then the diagnosis is not IBS. You have to keep digging.
Never diagnose IBS if there are red flags. Another functional issue that causes normal-looking scopes but miserable patients is lactose intolerance.
Right, the pathophysiology there is a specific enzyme deficiency.
Yeah, the tiny finger-like projections in the small intestine, the brush border, they just lack the enzyme lactase.
So when a patient drinks milk, the lactose goes entirely unabsorbed,
It travels all the way down into the colon where it acts as an osmotic agent,
meaning it pulls water from the body right into the bowel lumen.
creating osmotic diarrhea.
Yeah.
And then to make it worse, the normal colonic bacteria feast on that unabsorbed sugar.
They ferment it.
Exactly, fermenting it and producing massive amounts of hydrogen gas, which causes severe bloating and cramping.
And lactose intolerance can be primary, which is just a natural age-related decline in lactase production.
Which is highly prevalent in Asian, African, and indigenous populations.
Or it can be secondary, right?
Right. If a patient has a bout of infectious gastroenteritis, or say a flare of Crohn's disease, that mucosal injury temporarily wipes out the brush border enzymes.
Causing a transient lactose intolerance until the gut finally heals.
Exactly. Now, both IBS and lactose intolerance alter a patient's quality of life, but they won't kill them.
No. But the real danger is assuming symptoms are just a functional nuisance when they're actually masking a genetic syndrome.
We have to discuss Lynch syndrome.
Also known as hereditary nonpolyposis colorectal cancer, or HNPCC.
This condition operates at the level of DNA replication. Every time a cell divides in the intestinal lining, it must copy millions of base pairs of DNA.
And mistakes inevitably happen.
They do. Normally, mismatch repair genes act as a biological spell checker. They scan the newly copied DNA, they spot the typo, and they fix it.
But in Lynch syndrome, those mismatch repair genes, specifically MLH1, MSH2, MSH6, and PMS2, are mutated.
The spell checker is broken.
And when the spell checker fails, typos accumulate rapidly.
Particularly in areas of the DNA called microsatellites. These are just short, repetitive sequences of DNA that the copying machinery easily slips up on.
So this state of accumulated errors is what we call microsatellite instability.
Exactly. And when those typos happen to hit tumor suppressor genes, the cell begins to divide uncontrollably.
The lifetime risk for colorectal cancer in Lynch syndrome patients is just staggering up to 80%.
And unlike typical sporadic colon cancer, which takes years to develop from a benign polyp, these tumors progress from polyp to invasive cancer incredibly fast.
And they predominantly occur on the right side of the colon, don't they?
They do. But the systemic risk is what makes taking a thorough family history so critical.
It's not just colon cancer.
No, women with Lynch syndrome also carry an incredibly high lifetime risk of endometrial cancer, up to 60%,
Wow.
along with increased risks for ovarian and gastric cancers, too.
So imagine this clinical vignette. A 45-year-old woman presents to your clinic. She complains of cramping abdominal pain that gets better after she has a bowel movement.
Okay.
And she's been dealing with alternating diarrhea and constipation for a year.
So she meets the Rome-free criteria for IBS perfectly.
Exactly. But during the intake, she casually mentions her sister had endometrial cancer at age 48, and her father passed away from right-sided colon cancer at 55.
If you brush that off and just diagnose her with IBS, you have failed the patient. You must mentally run the screening criteria for Lynch syndrome.
The Amsterdam-Stecken guidelines.
Yes, often remembered as the 3-2-1 rule. You need 3 affected relatives with a Lynch-associated cancer spanning 2 successive generations with at least 1 relative diagnosed before the age of 50.
And in that vignette, she meets those criteria perfectly.
Which means she requires an immediate endoscopic workup. And if a tumor or polyp is found, the pathology lab will test the tissue using immunohistochemistry.
To see if those mismatch repair proteins are missing.
Right. And if they are, you proceed to germline genetic testing to confirm the actual Lynch syndrome mutation.
Because identifying that broken genetic spell checker changes the entire trajectory of her life.
And it dictates early screening protocols for her entire extended family.
It's so important. The GI tract really is a masterpiece of biology, but when it fails, the clues are always there if you know what mechanisms to look for.
We started with the rigid boundaries of the femoral ring causing strangulated hernias.
And the pressure cooker dynamics of a closed loop obstruction.
Then we moved into the cellular warfare of IBD.
The Th1-driven transmural tunneling of Crohn's disease. The termites.
Contrasted with the superficial mucosal burns of ulcerative colitis. And always remember how nicotine manipulates that mucosal barrier.
The smoking paradox. Finally, we explored the hidden mechanisms behind normal scopes, from the osmotic cascade of lactose fermentation to the broken DNA mismatch repair genes in Lynch syndrome.
It's a lot of ground to cover, but understanding the why behind the symptoms makes the exam so much easier.
For sure. Before we wrap up, though, I want to leave you with a quick thought experiment regarding inflammatory bowel disease.
Oh, I'm intrigued.
So we know that fecal microbiota transplants, essentially infusing a healthy donor's gut bacteria into a sick patient, they're showing real clinical promise in treating severe flares of ulcerative colitis.
It's fascinating research.
Right. But if the boundary between our immune system and our gut bacteria is so profoundly influenced by the microbes themselves, could the lifelong autoimmune cascade of something like Crohn's disease eventually be permanently reversed?
Wow.
Like, not by suppressing the immune system with heavy biologic drugs or cutting out sections of bowel, but simply by engineering the perfect personalized bacterial ecosystem from birth. Could we fix the entire house by just fundamentally changing the water and the plumbing?
It is a profound mechanism to consider, and honestly one that may redefine gastroenterology long after your exam is over.
Keep diving deep and trust the mechanisms. You're going to do great.